Hello, everyone. I'm Dr. Jeyaraj Pandian, President of World Stroke Organization. I'm extremely pleased to give this talk for the Basra Stroke Summit, the fourth meeting of the Iraqi Stroke Network. And I sincerely thank all the office bearers for inviting me to give this talk. So I'm going to talk about an important area of stroke care, that is the stroke systems, particularly focusing on the challenges that we have in low and middle income countries. And I will also talk about some of the models that are available and that can be applicable, and it could be implemented in any of the low and middle income countries. So I'm going to talk about stroke systems of care in low and middle income countries and cover the challenges that countries face. And even in the middle of those challenges, how can we improve or implement stroke care? So this slide is the latest information about the global burden of stroke from the GBD data 2021 and also the latest publication from World Stroke Organization. So globally, stroke is the second cause of death and the third leading cause of death and disability among NCDs. And there are 12 million new stroke cases every year and 7 million deaths and 94 million prevalent cases. If you see the distribution globally based on the DALYs by region, and you can see the maximum in Asia and Africa. Asia and Africa alone constitute 80% of the stroke cases in the world. And 1 in 4 people will have a stroke in their lifetime, and 53% of the strokes occur in below people 70 years of age, and 89% of the strokes occur in low and middle income countries. Sorry. The stroke systems of care. If we look at the healthcare systems in LMICs, we have government, we have private, sometimes it's a government and private partnership. And many countries, it is covered by the public healthcare system, the insurance. There are challenges, and most of the countries have private healthcare where it is out-of-pocket expenses for the patients and relatives. This is one important data from 2016 from Asia, and updated figures being uh, published soon. This is the ratio of neurologists to 1 million population. You can see the highest being in Japan and lowest being in Pakistan. India is 3 from the bottom here, about 0.96. It must have touched 1.25 per 1 million population. And so this is not a good figure. And this slide shows, based on the review that we did from our group, looking at the barriers, and the challenges, and you can divide into patient and healthcare system. I just summarized the barriers from the patient point of view: the lack of public awareness, socio-cultural beliefs, poor knowledge, and then access to services. And the health system, you have problems with staffing, infrastructure, funding, low physician awareness, insurance issue, training, and non-availability of protocols. So let's start with pre-hospital care. In LMICs, does it really exist? And if you look at the ambulance services, we can see here there are many LMICs where ambulance services are developed. However, we can see here there are several challenges here. You see the traffic, and in this traffic, how can you call an ambulance and ambulance goes and then brings the patients back? And it's always better for the patient to reach by any modes of conveyance and get the health, the stroke care. So pre-hospital, and now we have the emergency department. So what we need to do in emergency department? We need to have a clear protocol, clear description of the pathway, and ideally to implement stroke code as soon as the patient comes in. It's a suspected stroke patient. You activate the stroke code either through voice paging system or through a mobile app or WhatsApp group. That the entire team, that is from the emergency department, the radiology and the nurses, the stroke unit staff, the neurologists, neurosurgeons, and the neurointerventionists, they are all alerted. And in the emergency department, do minimal examination. The nurses quick vitals, take the blood samples, and the stroke physicians NHS and quick neurological examination, and send the patient for CT. And if the patient is eligible, just give the thrombolysis in the CT itself. So these are some of the steps that can really reduce the door to CT time and door to needle time. And in India, we have, through the Indian government, we are developing an integrated patient-centric emergency services by integrating many other emergencies, including ST elevated MI, stroke, acute respiratory illness, postpartum hemorrhage, maternal and child health, emergencies, snake bite and poisoning, in trauma and burns. This is an implementation research which is ongoing. We are also part of it. It's being implemented in 5 districts in our country, and this is going to give us a model which we can scale up across the country. It is not working as a silo, but integrating with the current healthcare infrastructure and the systems of care. So, models of stroke care. I'll just talk from India and then I'll move on to different countries in the world. And so, this slide summarizes the different models. One is the multidisciplinary team care that we have at CMC Ludhiana here, which is like an advanced stroke center or a comprehensive stroke program that is described in ASAHA and WSO. Then the specialist-led care. There is a neurologist, but he may or may not be interested in stroke, but drives the stroke program. And there is a rehab group and a multidisciplinary team. uh, the third model is physician-led care, which I'll describe, led by a physician where there is no neurologist available, and then a hub and spoke model where in the government sector, where using telestroke, how we can integrate, and a task sharing model also by training the community health workers. I'll start from the community-based stroke care model. So this we developed in rural Ludhiana, in 146 villages, 2 blocks of 240,000 population, where the ASHAs, the accredited social health activists, they are the health workers who are there for every 3,000 population in a village. And these were the ASHAs who were trained to identify stroke patients and report it to the research staff. And they were encouraged to call the 108 ambulance services, which was available free of cost. And what did we find in 2 years? The first person of contact was largely for in about 50% of the patients reached an unqualified practitioner in the village. And the ASHAs were able to identify stroke patients in more than 50% of the time within 4.5 hours. But they were going to the wrong hospital, despite they were encouraged to call the 108 ambulance. And the use of ambulance, you can see here, it's very, very minimal, around 2%, despite training them. And this is one of the landmark studies where we're able to see where the stroke patients go and how the health workers can identify this stroke patient within the window period. Based on this, we are developed further models. One is a physician-based stroke care in a secondary level hospital in Northeast India. This is a place called Tejpur here, and it's a small town where there's one medical college hospital and one private and affiliated hospital with our center. So first we started the stroke unit here. Before starting the stroke unit, we collected data in 125 patients over 6 months time. And then we asked them to identify a place within the hospital where they can identify it as a stroke unit. So 6 beds were identified, and we developed the training program. They were trained for about 6 months to 1 month, and the stroke unit protocols were implemented, and they collected the data again. So this is the stroke unit and the in-house CT scan that they have in this center. So this is the result. If we look at the overall complications between pre-stroke unit care and post-stroke unit care, you can see the reduction in complications. And then the key performance indicator like swallowing assessment, mobility assessment, multidisciplinary team, then starting secondary prevention drugs, all these improved in the post-stroke unit care. Some of the key performance indicators which will improve the outcome of stroke patients. And the length of hospital stay reduced by 1 day, and there was no difference in death or outcome because the high proportion of patients who were admitted in this hospital had intracerebral hemorrhage. That could be one of the reasons why the outcome was not good. But there was reduction in length of hospital stay, reduction in complications, and improvement in key performance indicators. Moving on to the government hospital hub and spoke model that we developed in 2016 in the state of Punjab, where we trained the doctors, nurses, physiotherapists, and then two of us, we went to different district hospitals and trained all of them and implemented the stroke program. So this is we have the hub here, two hubs, and these are district hospitals. Now we have expanded this program to all the districts, and all the district government hospitals have CT scan under the private-public partnership. A private group has installed a CT scan, and we have now signed a MOU with the government of Punjab, where we will be the hub hospital for thrombectomy, and by training, these district hospital will provide thrombolysis. Another, excuse me. So another place is Himachal Pradesh, which is a very hilly area in the Himalayas. And similar model has been implemented and published. And the state of Kerala in southern India, this is one hub, and these are the spokes. So this is another successful model. Um, so this is the hub and spoke model in the different state government. Mobile stroke unit, based on the experience from Ludhiana Rural Registry, we thought, we need to go to the patients. What is the feasibility of implementing mobile stroke unit? So in Tezpur and Dibrugarh, two places in the northeast state of Assam, we implemented in 2020 during the COVID time. Two MSUs were deployed by the Union Health Minister at that time. And so this is the MSU in Tezpur, and there was a toll-free number, and then this was integrated with 108 ambulance. So this is the data from Tezpur. This is a very preliminary one-year data. What we find is you can see the thrombolysis rate here before the deployment of MSU and after deployment of MSU. You can see the rise in the thrombolysis rate, and the onset to door arrival also decreased in this cohort. So moving on from India to Brazil, Brazil is a great model to replicate for middle income countries, where in 2008 there were only about 35 stroke centers. 2001 TPA was approved, and from 2008 onward there has been a tremendous growth in the stroke care and the implementation of Brazilian National Stroke Project and the Brazilian Stroke Network, and now there's a huge program of telestroke integrated in the public healthcare system, and we all know about the trial, the resilient trial published from Brazil on thrombectomy in LMICs. So Brazil is a great example. And this is some of the papers published. And you can see in 2008, the number of stroke units, 35 stroke units. In 2017, you can see about 149 stroke centers. So moving on from Brazil to Africa, we had a group called Organized Stroke Care across all income levels with funding from PHRI McMaster University, Canada. So this is a group that we were involved. We did this project in India and Africa. So basically, it's a stepwise before and after design study. the like what I described in Teshpur model, a physician's care model, where similar before implementation of stroke unit care collected data, and after implementation we collected information. So these were the KPIs that we collected from these centers. And so the sites from Rwanda, there were two sites from Rwanda we included besides India and a few other African countries. So this is the team which did the training. So this is a preliminary results. We can see here the age, gender, the stroke type. There is some difference in the stroke type. It's more an hemorrhage. Hemorrhage rate is about 40%. Onset to arrival, you can see here BP, and there is no real difference. And These are some of the KPIs. Use of antiplatelet drugs that has improved. The medications and BP management also improved, and swallowing screen improved. Mobility education improved, and there was not much difference in mortality, but some of the key performance indicators improved through this design. So moving on from Africa to Southeast Asia, there are 11 countries, over 2 billion population. So what we did is we partnered with WHO Southeast Asia Regional Office. We worked on different areas, developing documents, and later on moved to four countries like Bhutan, Myanmar, Maldives, and Timor-Leste. And online training in 2023, we went to Bhutan, and there are 5 stroke units now. There is no neurologist in Bhutan, only one neurosurgeon, and the physicians are managing the stroke program. Maldives, there are 2 neurologists and one neurointerventionalist. So again, a model, we had an on-site training program. And this is another successful model in Maldives. Now we have implemented in Timor-Leste, which is an island. There are 3 neurologists. Stroke care has just been implemented there. Through World Stroke Organization, we do this Global Stroke Alliance meeting, which was started in Brazil, and then we moved on to India in 2023. In September, before the G20 meeting, we invited 7 countries representation, health ministers, the health representatives, managers, and from India, there were 17 states were represented, and other countries, about 7 countries were represented. We signed the New Delhi Declaration, and also launched the World Stroke Organization and NABH, National Accreditation Board of Hospitals, Stroke Center Certification. WHO had rolled out this Stroke Center Certification way back in 2021 in Latin America, and we moved to India. We signed MOU with the National Accreditation Board of Hospitals, and the standards were released during the Global Stroke Alliance meeting in New Delhi. So, in conclusion, several models of stroke care available in LMICs. The most important thing is there has to be a stroke champion, capacity building, and you need to contextualize the stroke care through to the country, and then implement. We need to do a lot of advocacy work, talk to the government, and universal health coverage is important to do the large scale rollout of the program. And there are pragmatic solution offered by World Stroke Organization, which is published in 2023 Lancet Neurology October issue, which would be a guiding document for anyone to implement stroke care. And the model that we have developed in India through the WHO CRO, this is another great model, a top-down approach where we could work with the governments and the ministries to implement stroke care. So I sincerely thank my team, the WHO CRO office bearers, and my team at Christian Medical College, Ludhiana, and the entire stroke program members. Thank you very much.